So I should say good afternoon, everybody. But in Europe, I think that's morning. So good afternoon and good morning, everybody. Uh, my dear colleague, today I just to share my literature. My speak today's topic is surgical treatment of the complex spinal tumor. And let me introduce myself. I'm coming from Beijing Canada Hospital. I think maybe some of you know this hospital because this one is the biggest one in China. I mean, the neurosurgery department. And I'm Dr. Wenqing. And today I just want to make the introduction first. According to as we know, according to the location, spinal tumor can be divided into intramedullary, extramedullary, subdural, epidural, blah, blah, something like that. All depend on the location. But the treatment is mainly surgical resection. And how to definition the complex spinal tumor actually is usually, I think, characterized by long segment involved, combined vertebral spondylosis or vertebral bone or segment distraction. And the operators must be skilled, use a microsurgical and screw and fusion technique. And then I just want to share some of my cases to explain it carefully. The case one is a 72 years old female complained with neck pain with movement limitation for about 8 years and aggravated for about 3 months. And the MRI examination showed atlantal axial bone destruction with paravertebral, intraspinal, and posterior pharyngeal space and the left parapharyngeal space occupation. We think maybe diagnosis is chordoma. And the body check actually, the patient is almost normal, just pharyngeal reflex is negative. And as I have described, the preoperative diagnosis maybe is intra and astrovertebral occupational lesion. We think is a chordoma. I will show you the image later. And we just made the plan for this, the surgical plan for this patient. We think maybe we need to do the posterior C2 laminectomy and next year resection, same time, C1 to C4 implant fusion combined with transoral C2 vertebral tumor resection and 3D print vertebral body replacement and fusion. And this is the MRI before the operation. We can see it's a really invasive tumor. This tumor invasive, the paravertebral and the intraspinal posterior pharyngeal space and the left parapharyngeal space. So it's really invasive. And from the CT scan, the 3D CT scan, we can see clearly the C2 vertebral body was damaged. And then we also do the preoperative cervical spine, the CTA. That's one to figure out how to the vertebral artery, trace the vertebral artery. And before the operation, we do a 3D print process in order to replacement the C2 vertebral body during the operation. And that's what happened during the operation. We just first time we just fully exposed C1 to C4 spinous process and the vertebral plate, and we made 2 C1 lateral mass screws, and the C3 C4 lateral mass screw were placed. Then we use a sonotech ultrasound system to extrude the C2 bilateral lamina. And then we found a gray color tumor, and this tumor is incurring the vertebral artery and was growing posteriorly from the vertebral body. And we separate the tumor, and bilateral vertebral artery was isolated. Then we use a titanium connection rods to attach to the C1 to C4 lateral mass screws. After that, we close the posterior wound. And then we change the patient's position to the supine position. And we made a longitudinal incision was made to expose the anterior C1 to 3 vertebral body. And then we found the same color tumor. The tumor was separated microscopically and resected in piece, together with affected C2 vertebral body. And C223 end plate was scrapped and fabricated 3D printer process was placed with 2 screws fixed to the C3 vertebral body and 2 screws fixed to the lateral mass of the atlas. After we finish all this, I think the operation can be finished. And from the MRI posterior operative, you can see the tumor was almost totally removed. So it's made us satisfied. And from the post-operative cervical spine, we found the process and the screws position is, can be acceptable. So after all this, we found the pathology diagnosis is chordoma, and the patient's muscle strength is also normal. So this is my first case I want to introduce you. Another one is 34 years old female. The complaint is numbness in the left hand and the upper limb for about 3 months. And the cervical MRI report, a flight skull base atlan-oxyal dislocation, adenoid dislocation with occipital foramen stenosis. And at the same time, this patient 10 years ago was funded an intracranial occupation because the surgeons think maybe it's a benign tumor. So we do nothing for this patient. But this time, I think we need to do both of the lesion and the correct the dislocation. So our treatment plan for this patient is microsurgical posterior cranial fossa lesion resection and atlanto occipital deformity correction and occipital cervical fusion. So let's see what happened during the operation. This one is the MRI before the operation. We can see the lesion, the first ventricle lesion, and also together with atlanto-oxyal dislocation. And by CT scan, 3D CT, you can see very clearly the atlanto-axial dislocation and the deformity of the cervical bone. I mean the fusion of the bone. And also we did the preoperative cervical spine CTA. Just want to figure out the trail of the vertebral artery. And during the operation, the first time we put the patient in a prone position and with neurophysiological monitoring. And then we dissect and protect the bilateral vertebral artery. And we put an occipital plate and fix with 2 screws. Then we cut the dural and sustain in a Y shape. The tumor was located in the lower part of the first ventricle with cyst. After the cyst fluid, we found the cyst fluid was yellowish. And after totally remove the tumor, the dural was repaired with artificial one. And then we put 2 C2 pedicle screws, and the atlanto-oxyal joint was released microscopically. And then we use C-arm to double check the screws position. I think they were satisfied. And then the C2 pedicle screws and the occipital plate was attached and expandation with the titanium rod. Then we close the wound. This is the MRI, posterior operative MRI. You can find the lesion disappeared, totally removed. By CT scan, we can see much more clear how we correct the dislocation. This is the titanium rod and the plate, and the screw is okay. We can find the clevis angle, axial angle increased from 91 to 124 degrees. So after all this, we find the pathology diagnosis is epidermoid cyst and the patient's muscle strength. I mean the left upper limb, left upper limb and left lower limb are all changed from 3+ to grade 4, I think. So this one is the second case. And today I want to show you the last case is 29 years old female. This patient was complaining with numbness of the left limbs for about 3 months. And the CT scan, we do the CT scan first, the cervical MRI. I'm sorry, we do the first cervical MRI, but we find the tumor is really a very long tumor. We cannot see the lower part of the tumor. So then we do the thoracic, then we do the lumbar MRI, and we find this tumor is really long, really long tumor from C3 to S4 to S2 actually. But physical examination show just a little bit muscle strength weak. So let's see what tumor is this. This one is a cervical MRI. We cannot see the lower part. Then we do the thoracic spine. You can see the tumor located on the posterior part of the spinal cord. And then with some bubbling inside, like some bubble things, image inside. Is that the end? We think maybe that's the end. I mean, to the corners and medullas, but actually it's no. We just do the lumbar spine. You can see also from the sacral canal. We can see by the end of the sacral canal, there's still some enhancement needed. So what's your suggestion? Actually, if you want to maybe just a biopsy, maybe you want to move all this tumor. It's hard to make the choice because we think before the operation, some of our surgeons think it's an aplastic ependymoma with subarachnoid dissemination. Some of them think maybe it's a lymphoma. But after all surgeons in our department, we made the discussion. We think we still need to try to move as more as we can. I mean the tumor. So we use a microscopic spinal intramedullary mass resection, and maybe at the same time posterior cervical thoracic spinal cord decompression, and the implant fusion internal fixation should be done at the same time. During the operation, we explore the C5 to T12 process stenosis, and totally 4 bilateral lateral mass screws were placed in cervical 5 and 6. And 14 pedicle screws was placed in thoracic intermediately from 1 to 12, actually. And then we use a C-arm to double check. And then we do the C5 to T12 laminectomy. We found a tumor, actually, very dual tension was very high. And the gray tumor, medium texture, medium blood supply. Unclear tumor border and infiltrate grooves around the spinal cord and the root. During the operation, we put a frozen pathology, and the result was glioma. The tumor was resected piece by piece, and actually under microscope, and most of the tumor was removed. This is the pictures during the operation. We can see there's a really long incision. This one is just before we move tumor. This one is after we do the duroplasty, and this tumor is 23 centimeter long. And after the operation, we found the tumor from C5 to T12 almost removed totally. I think maybe it's 80 to 90% totally, but we skip the sacral canal because next time after diagnosis, pathology diagnosis, maybe we'll do another operation in the next few months. Then there's a pathology diagnosis. It's a very rare tumor, actually. It's a spinal diffuse little manageable glioneuronal tumor. Actually, this tumor is very rare, even in brain. And we just checked the literature, just a few case report in spine. So this one actually is WHO grade 1. It's a very benign tumor. And very lucky, the patient, after the operation, the patient is okay and recovered very good. So we just observed, maybe when the patient gets a new symptom, we'll do another operation for this patient again. That's all for my talk today, and thank you for listening, and welcome to visit our hospital in the future. I hope everybody here could have a chance to see me in Beijing. Okay, thank you.